I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Exercise is critical for good health, but when your joints or nerves hurt, it's hard to keep moving. What can you do? This is the People's Pharmacy with Terry and Joe Graydon.
Most people rely on nonsteroidal anti-inflammatory drugs. Millions take over-the-counter ibuprofen or naproxen every day. Others rely on prescription medicines such as celecoxib or meloxicam. What are the downsides?
Our guest today is an expert in regenerative medicine.
What does that mean? And how does it differ from the usual way to manage pain and speed recovery?
Coming up on the People's Pharmacy, the new science of regenerative therapies.
In the People's Pharmacy Health Headlines, flu season is pretty much over, but every year it takes a toll, especially among frail elderly people in nursing homes. A new study published in JAMA Internal Medicine asked whether using Tamiflu preventively could reduce hospitalizations and death. Researchers reviewed records covering 404 flu outbreaks in 318 nursing homes. More than 35,000 residents were covered by the study. When Tamiflu was given to at least 70% of the residents within 2 days of the first flu cases, there were dramatically fewer hospitalizations needed within the next 2 weeks. That's in comparison to situations where Tamiflu was not provided as a preventive medicine.
If you ask most cardiologists what causes heart disease, the answer is likely to be LDL cholesterol. They might also mention triglycerides, lipoprotein A, and high blood pressure. They probably won't consider lead. But a study of over 42,000 American adults who participated in the National Health and Nutrition Examination Survey tracked lead levels over many years. Those with the highest levels of lead in their bones were more likely to die from heart disease or stroke. People born in the 1930s and 1940s, before lead was removed from gasoline and paint, have the highest lifetime lead exposures. Further reduction in lead exposure should lead to lower rates of cardiovascular mortality. An editorial in the journal suggests that coronary heart disease is in part attributable to lead and other environmental exposures.
What is the cause of memory loss as people age? A recent study of mice suggests it might begin in the gut. Specifically, the scientists tracked microbiome aging throughout the lifespan. They found that gut bacteria producing medium-chain fatty acids accumulate with aging and drive inflammation. This, in turn, weakens the signal from the vagus nerve to the brain, with the result that the hippocampus falters. The hippocampus is critical to memory. In this study, the scientists introduced phage viruses to target the Parabacteroides, gut microbes causing the trouble. They suggest such interventions might counteract age-associated cognitive decline, although, of course, mice are different from humans. We look forward to research that might demonstrate its feasibility in people.
Fibromyalgia is a painful and chronic condition that affects soft tissue. It also causes fatigue, brain fog, and sleep problems. Millions of Americans are affected by this somewhat mysterious condition. A study published in JAMA Network Open reports that the combination of physical therapy and transcutaneous electrical nerve stimulation, also known as TENS, can reduce pain. Over 380 patients participated in the trial. Volunteers were randomized to receive PT plus TENS or physical therapy alone. After 2 months, those getting physical therapy plus electrical stimulation reported significantly less pain than those in the PT-only group. The authors note that the findings demonstrate effectiveness of this non-pharmacological intervention in reducing movement-evoked pain and suggest that the benefits of TENS are clinically meaningful in this population.
With warmer weather, tick season is right around the corner. In fact, it's already here in many parts of the country. Most people have heard of Rocky Mountain spotted fever and Lyme disease, but ticks can transmit over a dozen different diseases, from anaplasmosis and babesiosis to ehrlichiosis and alpha-gal syndrome. It's estimated that more than 500,000 people could be treated for Lyme disease between now and the first freeze this fall. But there is potentially good news on the horizon. Pfizer is teaming up with a French company to produce a vaccine against Lyme disease. It triggers your body to make antibodies to a protein on the surface of the Borrelia bacterium. These antibodies keep the Lyme-causing bacteria from infecting you and causing disease. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. You've heard us praise the power of exercise for good health, but it can be hard to keep moving when your joints hurt.
The usual approach is to take a non-steroidal anti-inflammatory drug, such as ibuprofen or naproxen. That is a short-term solution, and it comes with a handful of side effects. What else could we do to alleviate joint pain?
To help us understand some new options, we are talking with Dr. Tom Buckheit. He's done research on immune mechanisms that resolve inflammation and pain. He serves as an adjunct associate professor at Duke University and collaborates with colleagues at the Center for Translational Pain Medicine. His new book is Healing Joints and Nerves: Immune Stimulation and the New Science of Regenerative Therapies.
Welcome to the People's Pharmacy, Dr. Tom Buckheit.
Thank you, Terry, Joe. It's wonderful to be here. I have to say, I've been listening to your show since 1998 when my wife and I moved to North Carolina, and it's just a delight to be here. So thank you.
Thank you so much for joining us. You know, Dr. Buckheit, I'd have to say that if people ask us, and they occasionally do, what's the one most important thing we should do for good health? The answer is simple. We say exercise. Exercise is absolutely critical. Move your body, even if it's just for a walk every day if you can. And if you can do more, so much the better. Terry is a black belt in karate. I love to play tennis. We love to move our bodies. There's only one problem. What interferes with exercise? Pain, injuries. You know, when you exercise a lot, you sometimes hurt yourself, and then you have to take a break. And for people who really enjoy exercising and want to do it, that can be both psychologically and physically very challenging. So help us understand your field and how to help people get back moving again once they hurt themselves.
Well, Joe, you brought up a really good point. Exercise plays a very important part of health for all of us. And I think we increasingly know the reasons why. One of the core topics that I talk about and like to focus on is the importance of healing and our body's innate ability to heal. We turn those healing mechanisms on by stimulating certain immune cells, and one of the most powerful ways of doing so is exercise. Exercise does it, good inflammation does it, some other regenerative therapies do it, and these are all bound together by the same healing mechanisms. But you're right, exercise is core to that. The challenge a lot of people run into is that they have an injury, they have an arthritis problem in a joint, they're unable to do that, and their question is how do they get back to that activity? What I use the phrase orthopedic limbo. That individual is in orthopedic limbo. They have an issue that prevents them from pursuing their tennis or their karate or just walking the dog or spending time with friends. And they're trying to figure out how to get beyond that and move again. But they're not necessarily a surgical candidate. So what can they do? And that's one of the reasons I like to focus on these things that stimulate a healing response and stimulate recovery to function.
And we'll talk a little bit more about some of those strategies because they're really intriguing. But first, why is exercise so important?
Exercise is important because it produces good inflammation. And
Whoa, wait.
Inflammation is good?
it's an important topic, right? I think a lot of people hear inflammation, they think immediately inflammation is always bad. We have to get rid of it. We have to suppress it. We have to drive it down. And there are, and I think you've talked about this in your show before as well, but there are good components of inflammation. We have to be careful we don't throw the weed out with the chaff with that. So chronic inflammation is always bad, right? It damages tissues, it drives arthritis, it drives chronic pain. But short-term, brief, and fairly strong inflammation is how we heal. If I had an ankle sprain and I bled into that ankle sprain, that injury, that inflammation is what heals that ligament eventually. You bleed, you release growth factors, you turn on these immune systems. Exercise does that same thing, but it's good inflammation. So I think of good inflammation as short, reasonably strong, and able to flip an immune switch that begins a healing cascade.
Dr. Buckheit, in Healing Joints and Nerves, you talk about the 3 pillars of exercise. What are the 3 pillars, and why do we need 3 of them?
Well, great question. There are certain tremendous advantages of aerobic exercise. We know that people who have a high aerobic capacity and who can exercise at high levels with, it doesn't matter if it's running, swimming, playing tennis, that's linked to longevity. We also know that muscle mass, and increasingly people talk about muscle mass being very important and strength being very important to strengthen joints. And we see this with studies of even arthritis patients who have less joint pain if they can strengthen the support structures of that joint. And then, of course, balance is such a wonderful thing, whether it's through balance exercises or yoga or Tai Chi, just such wonderful exercises that brings all this together of strength, stability, and the ability to stay on 2 feet without falling down.
I want to know how exercise helps recovery, because that's, we often hear, ice and rest and, just don't do anything for a week or two, because, a lot of tennis players, they want to get back on the court as fast as possible, and they're told, oh, no, you got to rest those joints. That you pulled a muscle, you better let it rest. And you're suggesting that exercise actually helps with healing.
It absolutely does. And it helps with healing because it flips that immune switch and turns on this healing cascade. There was a study that I think showed this well. It was patients who had ankle injuries, and they were immobilized in crutches after an ankle injury, and they measured the cartilage in their knees as a marker after immobilization. And they found out that those who were in crutches for long enough actually had less cartilage in their knees. Their knees were never injured, but it was the lack of exercise that decreased the health of their joint cartilage. So our bodies need this. They need intermittent stress. And I think this we have kind of fallen into this trap where we think all inflammation is bad. I would push back on that. I think we need to stress ourselves, whether it's studying for an exam, whether it is playing a tennis match, whether it's going for a brisk walk. Our bodies use stress and use these intermittent bouts of exercise to strengthen.
I'm assuming we stress ourselves appropriately.
Exactly. And that's the Goldilocks phenomenon, right? If you want enough stress. So to look at it kind of biochemically, if you look, there are a lot of inflammatory proteins that a muscle will release if it's been exercised. Matter of fact, some of those will go up 100-fold. And they cause some of the aches that we're familiar with after a strong workout. But those same inflammatory proteins will then flip and help our bodies to produce some of the anabolic proteins and things that rebuild tissues and strengthen tissues.
How does exercise help nerves regrow? You've said it does.
That's a great question. And that came as a bit of a surprise to me when I started doing research on this a bunch of years ago. We all thought of, and I think that a lot of the medical profession thinks of, well, once you have neuropathy, it's just a done deal. You're never going to recover from it. Your nerves are gone.
And neuropathy is nerve pain.
Right, nerve pain and nerve dysfunction from the nerve pain. And it can be different kinds. There can be sciatica, somebody experiences after a disc herniation in the spine. There can be dying back of the nerve, somebody experiences because of diabetes or they've had chemotherapy in the past. Those nerves can recover, and exercise is actually one of the important tools to help those nerves recover. It does through a few things. Some of the growth factors I talked about that exercise releases. It also does it through these very small immune particles called exosomes that we researched in lab, that I've researched and looked at for a long time now. And they also help nerves recover. If we think about it, nerves are energy hogs. And anything we can do to improve their energy supply through mitochondrial function is going to help the nerve to recover. And so exercise and some of these other therapies can improve nerve function. They may not help a nerve regrow from the back all the way down to the foot, but they can take the nerves that are already there and help them work better and help people function better.
One of the things that most physicians, not all, but most physicians, especially the orthopedists, like to prescribe are the non-steroidal anti-inflammatory drugs. So if you sprain your ankle, if you hurt your shoulder, if your back is giving you trouble, out come the NSAIDs. And of course, they're also available over the counter: Aleve, naproxen, ibuprofen, Advil. And so people have come to just love non-steroidal anti-inflammatory drugs. You've suggested that they might be counterproductive in some ways.
Well, they can be. And anti-inflammatory medications, what we call NSAIDs, they can, in fact, impair the strengthening our body's experience with a workout. And this has been looked at in patients. This has been looked at in laboratory studies of laboratory animal models, that if you slow down or stop the inflammatory response to exercise, you also impair the muscle building and the strengthening you get from that workout. So NSAIDs, sometimes we may need to take them for a severe headache or a pain that's keeping us from moving. But if we take them chronically, they impair the very healing mechanisms that our bodies need to stay healthy and recover.
Now, if you were to take an NSAID for a workout, when should you take it and why?
That's a great question. So I think the clear answer is after the workout, not before.
A lot of my tennis buddies call it vitamin I, and they take it religiously before they go out on the courts. So you're suggesting maybe not such a good plan.
I think if one can hold off until after the workout and wait as long as you can, it's better off than before. I think it's probably better for our joints and our bodies to have a shorter workout without an anti-inflammatory than a longer workout with. Now, that's never been studied in a randomized controlled trial, but I think it's a good idea to avoid taking it before whenever possible.
You're listening to Dr. Tom Buckheit, an expert in pain management and founder of the Triangle Regen Medicine and Biologics Center.
After the break, we'll learn about steroid shots in joints.
What might work to ease osteoarthritis pain?
You may have heard of PRP and stem cells. We'll get the details.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is brought to you in part by Caraway. Their pots and pans and kitchenware are free of toxins and easy to use.
Are you getting ready for spring cleaning? It's so much easier when you have cookware that's super easy to clean and lovely to look at. I really appreciate that Caraway cookware comes with its very own customized storage solutions.
I especially appreciate the third-party testing and verification as non-toxic by independent labs. We love that their food storage containers and cutting boards are made without plastic. I've been doing my best to avoid plastic for decades, and with these products, it's so much easier.
Caraway's cookware set is a favorite for a reason. It can save you up to $230 versus buying the items individually. Plus, if you visit carawayhome.com/PPOD10, you can take an additional 10% off your next purchase. This deal is exclusive for our listeners, so visit carawayhome.com/PPOD10 or use code PPOD10 at checkout. Caraway, non-toxic kitchenware made modern.
This episode is brought to you by Progressive Insurance. Do you ever find yourself playing the budgeting game? Well, with the Name Your Price tool from Progressive, you can find options that fit your budget and potentially lower your bills. Try it at Progressive.com. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law. Not available in all states.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at getsonu.com. That's getsonu.com.
Today on the People's Pharmacy, our topic is healing joints and nerves. What are regenerative therapies and how do they work?
Our guest is Dr. Tom Buckheit, founder of Triangle Regen Medicine and Biologics Center. Dr. Buckheit was chief of pain medicine at Duke University from 2013 to 2019 and is an adjunct associate professor there. His new book is Healing Joints and Nerves, Immune Stimulation and the New Science of Regenerative Therapies.
Dr. Buckheit, corticosteroids, very popular on the tennis court. Oh, my shoulder hurts, I need a steroid shot. Oh, my back aches, another steroid shot. Oh, my knee is giving me trouble, another steroid shot. Doctors love them because people feel better, oftentimes immediately after or within a few days, and it lasts sometimes a couple weeks, for some people maybe as long as a couple of months. But there's a downside. What is it?
Well, there is a downside, and it is true that a steroid injection can produce rapid pain relief and can be helpful in some people to get them back to the gym, get them back to the workout. My concern with steroid injections or corticosteroid injections is the repeated use of them. There was a study done now almost 10 years ago, and that was a randomized control trial looking at individuals who had osteoarthritis of both knees, and one group had saline injections into the knees, the other group had corticosteroid injections. And at the end of 2 years, there was no difference in the pain, which didn't really surprise a lot of people because we know steroid injections tend to be shorter lived. But the individuals who had repeat steroid injections actually had less cartilage in their knees than the ones who had saline. And I feel like that study was a bit of a wake-up call to all of us, and I did a lot of steroid injections at the time as well because patients seemed to do well with it. But it made me start rethinking how I was approaching this concept of how do you treat someone with joint pain, some arthritis, they don't need surgery, again, the patient orthopedic limbo. We've relied on corticosteroid injections as a bit of a crutch, and I think we need to flip this paradigm and think about how do you improve cartilage health? How do you improve tissue health? This year is the 75th anniversary of the first corticosteroid injections that were done for arthritis pain. And it was a remarkable event, but interestingly, I've gone back and I've read a lot of the historic literature on corticosteroids and their use in arthritis. And the physician who published the paper noted that 37 of 38 of his patients did extremely well after the steroid injections. But what he didn't emphasize is some of the patients required up to 17 injections per year to maintain that.
Oh, my.
And I think that's the part that we've been missing within the medical world, is that a steroid injection can be an important tool, but I would argue it's an overused tool in a lot of settings.
Well, 17 injections a year definitely sounds like it's being overused. And one of the things that steroids do is they suppress the immune system. What's the impact of long-term immune system suppression?
Well, gosh, there's a lot of things that would do. Obviously, we could go into, bone health and bone density. We could go to the endocrine system and looking at, someone who's borderline diabetic who becomes frankly diabetic after repeated steroid injections. We can look at tissue healing as well. But if I kind of focus on the cycle, I think we need to think of our bodies as cycles, right? We cycle day and night. We sleep. We wake up. And exercise and this immune stimulation that keeps our joints healthy is also a cycle. It's a cycle of exercise and recovery. And anyone who's trained knows this inherently. You have hard workout days, you have recovery days.
Mm-hmm.
And I think if we use tools like steroids or anti-inflammatories continuously, we remove those necessary cycles of stress and recovery, stress and strengthening. And steroids, I think, act in some ways, have similar effects as the anti-inflammatories do. And we can talk about a study as well that dives into that.
Well, I'd like to talk about one of the reasons that a lot of people get steroid injections and one of the reasons why they take a lot of the anti-inflammatory drugs, and that's osteoarthritis. And it can affect your fingers, it can affect your shoulders, it can affect your knees, it can affect your hips, it can affect just about every joint in your body. And I remember someone saying a long time ago, well, exercise is going to make it worse.
Right. That's the old wear and tear hypothesis. And that was the hypothesis about osteoarthritis for years, which is that, well, you're just wearing your joints too much and they're just wearing down. That ignores the fact, though, that exercise restores cartilage health. And, some people talk about, well, someone loses weight and they have less joint pain, and it must be less weight on their joints and less wear and tear. But the hand arthritis also gets better if you lose weight. And so I think it's an issue of a systemic chronic inflammatory problem that's improving with weight loss. We've then moved from the wear and tear hypothesis to the inflammatory hypothesis of arthritis. And it made sense. We can see inflammation on ultrasound. If we do an ultrasound exam of a joint, you can pull out fluid and it looks inflammatory if you look at it under biochemical analysis. The patients feel the inflammation. But if you treat the inflammation, it doesn't improve the disease state. And that's been shown so many times. There have been at least 4 studies of strong inflammation suppressors in the rheumatoid arthritis drugs that have been looked at for osteoarthritis. They did not work. There have been studies of corticosteroid injections. Again, they tend to worsen the problem, not make it better. The concept that I think we need to focus on is osteoarthritis is a chronic wound, and we need to think about how to heal the wound. If you heal the wound, the chronic inflammation also improves as well. And that explains, I think, the chronic wound concept explains why studies have failed in the past and why some of the therapies we do now, such as some of the regenerative therapies, can actually have a role.
Well, maybe you could tell us a little bit about what could work for osteoarthritis, because so far we've talked about things that are less than ideal. The steroid injections, the NSAIDs, those are the most common. And there have to be things, maybe even a lot of things that can be useful.
Well, first, what the heck is regenerative therapy? And second, why would exercise, because you've sort of alluded to that, be helpful for osteoarthritis? So give us the 1-2 punch.
I always think of it as we start with a healthy diet, healthy fruits, vegetables, healthy fats, add exercise to that. And that is the core, I think, of keeping joints and nerves healthy.
And the rest of us.
And the rest of the body as well, right? What's good for your heart tends to be good for your joints as well, right? It's enough for a lot of people, but it's not enough for everybody. And it's not enough for people who have had injuries in the past. It's not enough people who have a systemic inflammatory issue going on. And that's when I think about layering on what some people call regenerative therapy. Some people may call it an orthobiologic. These are ways of stimulating those immune cells I talked about and pushing them into a state where they are resolving and building tissues again. where they've been suppressed in the past and they're kind of low level, they're chronically inflamed, they're not behaving well. You need to push them into a new state, this resolving state. And I think of it not as suppressing inflammation, but resolving it. And that might sound like a little bit like splitting hairs a bit, but if I think of suppressing inflammation or fighting inflammation, I think of you're putting a drug on it to tone it down temporarily. When I think of resolving inflammation, I think of our body's natural processes that resolve it. There are some wonderful fats that do this. They're called SPMs. They're derivatives of omega-3 fatty acids. Our bodies use those and other compounds to naturally resolve inflammation. Matter of fact, in the lab, some of those compounds are more powerful than morphine in animal models of nerve pain to resolve inflammatory pain in models.
Wow, that's amazing. Tell us, how do you do that?
Well, our bodies make these compounds. So,
And you say they make them from omega-3 fats like fish oil or walnut oil or the fats that we get in very small quantities from dark green leafy vegetables.
precisely. If we eat a diet rich in healthy fats, as you pointed out, from walnuts, nuts, cold water fishes like salmon and anchovies and tuna, as long as it's not too high in mercury, though our bodies take those fats and they make other compounds from them, and those other compounds will resolve inflammation. They work with the leafy green vegetables and all the colorful vegetables that I think you all have talked about that are so important to overall health.
We love talking about colorful vegetables.
But that all works together. And that, to me, is the foundation of really regenerative medicine, is what our bodies are already doing and how can we promote those activities themselves. A lot of people focus on a procedure and injection, and they can be helpful, but we have to start with our own bodies.
So it sounds like diet is critical. And the healthy fats, the omega-3s, are especially beneficial so your body can do this resolving stuff. And exercise is also important, presumably if it's, mild exercise if you've injured yourself so that you don't re-injure yourself. But what are some of these other agents, this regenerative process that you're talking about that you practice when you see patients who have had injuries?
Yeah, great question. I would put them in 3 different categories. Things like platelet-rich plasma, which we'll talk about, stem cells, or something called autologous conditioned serum. Some people know it as the Regenerative program. PRP, or platelet-rich plasma, is probably the one I'd start with because it directly activates our own healing cascade. Interestingly, back to my analogy of the wound and a joint, PRP was first used to treat wounds. It was first used by a wound surgeon, published in 1986. It's been around for a while. Then it was used in the oral surgery field to heal non-healing wounds. And then it kind of leapt into the world of arthritis and nerve issues and things like that. But what it is it's if you take blood and you spin it down and you collect the platelets and the white blood cells there, they can act with the growth factors and act in a way to flip that immune switch I was talking about to start to rebuild tissues. So it's a way to almost use that, almost like exercise. It's almost like exercise in a tube in a way. You take that blood product and you inject it onto a knee or a shoulder or hip, and it further turns on those healing mechanisms that our body can have but aren't always strong enough by themselves.
Let's make it very clear. We're not talking about someone else's blood. We're talking about our own blood is being removed, and I assume it's not gallons, it's just a little bit. How much?
Well, actually, that's a very good point. You need a fair amount. You need a fair amount because you have to make sure the PRP dose is right.
So how much is
60 to 120 milliliters.
So for people who are not metric.
So a cup is roughly 250 milliliters. So we're talking less than a cup.
Less than a cup.
Right. So it's not gallons. It's
exactly.
It's a little
maybe
bit
a
of
half
blood.
A cup, more
half
or less.
A cup. And you're removing that blood, and then you're spinning it down, and you're extracting the platelet-rich plasma.
Exactly. Now,
and re-injecting it.
PRP has become quite controversial. One of the reasons is because there have been a couple of very large trials that have shown it hasn't worked. But if you go back and analyze the studies, which I've done with some colleagues, it turns out that if the plasma isn't rich in platelets, it doesn't work. And it sounds a bit, axiomatic,
Okay,
but
right. So you have to have the right stuff in
you've
order
gotta
for
have
it
the
to
right
work the
dose.
way it's intended.
Exactly.
So is it a little less controversial now? Are there studies demonstrating benefit?
There are with high doses, and I think that's the key. If the dose isn't right, it just doesn't work. And that's why it's important. And one of the things that I do is I measure the doses of every PRP to make sure that dose is correct.
So our listeners and a lot of your colleagues learn from stories. Can you share a story with us about somebody who came to your practice in pain and maybe not able to exercise, and that person benefited from PRP?
I think it's a common scenario. I would use the scenario of someone who's had a prior ACL tear or a lot of
ACL being
a knee ligament tear. Especially young women athletes seem to have this quite commonly. The problem with these tears is that it sets them up for early arthritis. And
we know the surgery itself has some issues.
right. Well, then in joint replacement surgery can be very successful, but you also don't want to do that when you're 45 years old and still active because you may wear out your joint. You might wear out the replacement. And that to me is a good candidate for what I would call regenerative therapy or biologic therapy, where you can turn this inflammatory process, this chronic wound of a knee that's had a prior injury and can't quite get into the healing mode, and you can add PRP or another therapy to it to really turn the corner of that knee and allow it to start healing again.
What other joints benefit?
Really, any joint can benefit. Most of the studies have been done in knee osteoarthritis because it's so common.
So common and so troublesome if you have it.
Precisely. But shoulder, hip, other joints, and actually there's some very good literature for PRP for ligaments and tendons. So for the outside of the hip, the trochanter, or tennis elbow is a very common scenario. Again, that's a scenario where a tendon is there and it's just not healing up, and you want to add growth factors to it to get it to heal.
Are the orthopedic surgeons embracing PRP these days, or are they still a little resistant?
Well, I think the orthopedic community is embracing this to a fairly significant extent. And it does compete. There's a question of does it compete with surgery for some people, but I think it has a clear role. And as we understand what makes a regenerative therapy more effective, they're going to, I think, gain more and more acceptance.
Well, what about side effects of PRP?
The main side effect for PRP is a flare-up of pain. If you think about it, you're turning on an immune system, you're turning on these white blood cells. So I tell people it's an expected side effect. If they're going to have oftentimes discomfort, sometimes even swelling for a few days afterwards.
So you're creating short-term inflammation to overcome the long-term inflammation.
Just like exercise.
You're listening to Dr. Tom Buckheit, author of Healing Joints and Nerves, Immune Stimulation, and the New Science of Regenerative Therapies. Dr. Buckheit founded the Triangle Regen Medicine and Biologics Center. His research has focused on immune mechanisms that help resolve inflammation and pain. From 2013 to 2019, he was chief of pain medicine at Duke University, and now he is an adjunct associate professor there.
After the break, we'll consider the case of a long-distance runner who has developed hip arthritis that interferes with his running.
Do stem cells help cartilage grow back? If not, what are they doing to ease pain?
What is prolotherapy, and how does it work? Injecting dextrose, that's sugar water, sounds almost like a placebo treatment. Is it effective, and how long has it been available?
It does sound like a placebo. You'll also find out about autologous conditioned serum. What is that? How does Dr. Buckheit use it?
Some of the same therapies that work for joints can also help nerves. How do they work for that?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This episode is brought to you by Progressive Insurance. Do you ever find yourself playing the budgeting game? Well, with the Name Your Price tool from Progressive, you can find options that fit your budget and potentially lower your bills. Try it at Progressive.com. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law. Not available in all states.
Thinking about GLP-1s to help with weight loss? Go micro with Noom. You start off with a small dose of medication, then gradually increase as your body reacts. The Noom GLP-1 microdose program starts at $79 and is delivered to your door in 7 days. Start your microdose GLP-1 journey today at Noom.com. That's Noom.com. Noom. Micro changes, big results. Initial 3-week subscription and 4 weeks of medication from $79 plus tax, and $179 per month plus tax for 7-week subscription thereafter. Final pricing depends on program selection.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at GetSonu.com. That's GetSonu.com.
Today, we're discussing some new therapies for arthritic joint pain. We'll also find out what can be done for trapped nerves. Have you ever heard of prolotherapy? It involves the injection of sugar water into an injured joint. How could that possibly be beneficial?
To learn more about prolotherapy and PRP, as well as other new options, we're talking with Dr. Tom Buckheit. He's done research on immune mechanisms that resolve inflammation and pain. He founded the Triangle Regen Medicine and Biologics Center. Dr. Buckheit serves as an adjunct associate professor at Duke University and collaborates with colleagues at the Center for Translational Pain Medicine. His new book is Healing Joints and Nerves, Immune Stimulation and the New Science of Regenerative Therapies.
Dr. Buckheit, I'd like to ask you about a scenario. I know a person, happens to be related to me, not Joe, not Dave, but this individual actually dislocated his hip on a construction site when he was in his early 20s. He is now 75. He has been a long-term, long-distance runner, and he has recently had a problem with hip pain on the hip that he dislocated back when he was a young guy. So he went to the doctor, and the doctor said, yeah, you've got a lot of arthritis there. What would you advise this fellow for relieving his pain? He said, well, I don't think I'm going to be running anymore. He does walk. But what advice do we have?
And he loves to run. I mean, this is a long-distance runner for decades.
It's a common scenario. And to me, there are a couple questions. What is their level of function they're at now? What do they want to be? How much cartilage do they have? It's easier to use some of these regenerative therapies for people who have some cartilage left. And I always think of this as a way to improve tissue health, improve the health of tissues and cartilage that's already there. It's not going to regrow cartilage. Mm-hmm. Even stem cells don't regrow cartilage, and that's something we can talk more about. But it's a misconception out there.
So people think that stem cells will regrow cartilage.
People think that they do, but they don't. And there's, I think, a couple of reasons why. The stem cell story is a really interesting story of great science that's been misinterpreted over the years. And we can talk a bit about the details of that.
But I'd like to get back to the PRP alternatives. So you've made a strong case for platelet-rich plasma, PRP. What other regenerative strategies do you have, and how else can they help either osteoarthritis or an injury or some other situation that is interfering with exercise?
It all kind of depends on the severity, what's going on, what the joint looks like. And when I say looks like, what does it look like under MRI, under X-ray, under ultrasound? and what does it feel like to the patient. It can be if it's a tendon or ligament issue, you can use things like prolotherapy to stimulate a healing response.
That's great. We want to know what prolotherapy is.
Prolotherapy, what is it?
Prolotherapy was commonly used. Now we use it, dextrose, actually. Dextrose,
Sugar water. Sounds like a placebo.
It amazingly, it does sound like a placebo, but if you put sugar water in high enough concentration, it will set up an inflammatory reaction and that same immune response we've been talking about.
And prolotherapy's been around for decades.
It's been around for 70, 80 years. Absolutely.
And a lot of times, I think some of your colleagues have said, yeah, that's nonsense. But you believe it works.
I do, and I use it most often for tendons and ligaments that they need to flip that switch and they need to go into healing mode because it will set up that immune response.
And so you're injecting sugar water, dextrose, into the area that is painful.
Exactly. Now, it's partly what you're injecting, it's partly how you're injecting, because you do a technique that actually purposefully does minor injury to the tendon or ligament. People call it a fenestration. It has different words to it. But you do a little bit of a peppering technique of the tendon, and you add this high concentration of sugar water. The body responds to that inflammatory cascade and says, we have a problem here to fix. And the body sends in its messengers, just like it's been an ankle sprain or another injury, sends in its white blood cells, and then they start to get to work. So it's really a calling card for our immune systems.
So here again, you're creating a short-term inflammation to overcome this chronic inflammation that is causing the pain. You've said a couple times that the body needs to flip the switch. Can you tell us a little bit more about that, please?
Yes, and your description was perfect. That's exactly it. If we go back to the healing cascade and back to, say, the ankle sprain, there's bleeding, there's platelet release. The platelets not only release growth factors, but they pull in white blood cells. One of those white blood cells is called a monocyte or macrophage. There's been a lot of research into the macrophage that can change personalities. I liken it to the Incredible Hulk. Bruce Banner becoming the Incredible Hulk. He's a mild-mannered in the bloodstream. He finds an injured tissue. He becomes the Incredible Hulk and very angry. But once he can resolve that anger, the anger of that macrophage, he can become kind of a subdued Hulk and start rebuilding these tissues. And so to me, it's the work of the macrophage, which is this white blood cell, that is key for healing. And most of what we're doing with all these therapies is finding ways to flip the switch. And when I refer to the switch, I'm referring to the macrophage switch.
So we've talked a little bit about PRP. You've mentioned prolotherapy, which is injection of dextrose into the area of pain and discomfort. What other regenerative therapies are there?
There's stem cells, and then there's autologous conditioned serum, which is one that I've researched in lab and clinically
What
as well.
is that?
That is a therapy that was developed in the 80s and 90s by a German orthopedic surgeon, Dr. Peter Wehling. And they were looking at ways to, again, resolve inflammation. And they found that if you take blood and let it clot over an extended period of time, again, the blood clot being important here.
Platelets.
Exactly. Platelets and the things that the immune cells, actually immune stimulation, if you stimulate that system in a test tube and then you pull off that serum, it has all kinds of inflammation-resolving proteins in it and growth factors. And it's been studied. It's been used. There are a lot of athletes that fly to Germany for this therapy. I use this therapy as well in my clinic now in Chapel Hill. But there was part of it that didn't make sense because it was lasting longer than you'd expect just a growth factor or an anti-inflammatory protein to work. So that's when we started looking at the mechanisms. And we found out that actually a lot of the effect of it is driven by these tiny immune particles called exosomes that can reprogram how cells behave. So in a way, it's kind of reprogramming tissues and how tissues behave. And that, to me, I think was the kind of the secret of the sauce, which is it's allowing cartilage, allowing a tendon or ligament to become more youthful, for lack of a better term, because it's being reprogrammed.
So how would somebody who's either injured themselves, as Terry's relative, won't mention any names, with his dislocated joint and the osteoarthritis that has resulted, or an athlete who is elite, one of the great basketball players at Duke University who comes to you and says, "Oh, I got to get back in the game next week." How do you do this autologous thing that you're talking about? How do you make this stuff, and how safe is it?
Well, right now we make it in the lab. We built a lab for this, and it's actually quite safe. It's been used for 20 years, a couple 100,000 patients across the globe. It's been used more in Europe than it has in the United States, but it has a very long track record, partly because the quality control of it is just so tight. There are only a couple of places, there are only about 10 places in the United States where you can get it. And the lab, our lab technique, and everybody's trained very highly. So I think the key to it is the standardization of processing and the quality control of the processing.
And what exactly is it?
It's a serum product, so serum from blood.
So again, we extract some blood from the individual, and you do the magic sauce thing.
Yes, exactly. And then occasionally things are added to that magic sauce, depending on the individual in front of you. And it's injected in several different times, usually over the course of a week or so.
We have spent most of our time together talking about joints, bones, cartilage, and tendons and ligaments. And I would like to ask about nerves, because healing joints and nerves, you're talking about nerves, and nerve pain can be really awful. Why does it last so long?
And what can you do about it?
Right, importantly. Yeah, why is it there and what do you do about it? A nerve will cause pain if it's firing on its own. It has different names, autonomous firing, but if a nerve is compressed, strangled, or otherwise restrained, it tends to fire on its own spontaneously. And that spontaneous firing we feel is pain.
So sometimes we call that entrapment or impingement. They've got fancy terms for it, but it's trapped.
Exactly. If you trap a nerve with a disc herniation in your spine, you're going to have rip-roaring sciatica down your leg, and that's an entrapped nerve. If you have carpal tunnel and you have an entrapped nerve in your wrist, that's going to cause nerve pain in your hand. If you have a nerve that's entrapped around an old surgical scar, that's going to become entrapped. And so the key is there are ways to decrease the firing of the nerve with drugs, but to me, that's an important part to free the nerve up so it's no longer entrapped. And so that's a lot of things that I do are freeing nerves up. And
how do you do that?
There's a technique that's called hydrodissection that we do. And basically, it's kind of gently injecting fluid of one of several different types around a nerve to open the space around that nerve so it can glide more freely through that space. And it's a technique that makes sense. Years ago, I'm old enough to have been doing nerve blocks before ultrasound was ever used. And occasionally, we'd see patients who got better longer term after a nerve block, and I kind of scratched my head trying to figure out why is this person better long term, because all we did was shut the nerve off for a few hours. In retrospect, we were probably doing hydrodissections without knowing it. Now we can see it. So under ultrasound, you place the needle very carefully around the nerve, and you use a fluid to open the space up. So you don't have to do it surgically now. You can just do it through a needle and through ultrasound.
So that's what the ultrasound is for, to be able to visualize what you're doing.
Precisely.
How to do it right.
Precisely, and to make sure you get good separation of the tissues with it, because you can see it almost looks like a halo around the nerve when you're done.
How well does it work?
It depends on the nerve and depends on the entrapment. If there's a true entrapment around a scar, it can work wonderfully, and once or twice it can completely relieve pain. Other areas, if the nerve is sick for other reasons, because of diabetes or other issues, it may work partially, but my philosophy is if there's ever an entrapped nerve, you want to release the entrapment first before you start adding drugs to it.
And one other thing, what about side effects?
Side effects of hydrodissection are very low as long as the person doing it has a good view and experience doing it, because if you put a needle into a nerve, you can injure the nerve. Mm-hmm. So you have to be very delicate and very confident in being able to place the nerve gently around it, but not in it, and that's the key.
Are there any nutritional supplements that can be helpful for people with neuropathy?
I'm not an expert in supplements, but there are a few that I look at. I look at things that make nerves healthier and make our mitochondria work better.
Such as?
Well, one of my favorites, partly because so many people are taking statins, is making sure they're on CoQ10.
Right.
So I look at that. I am a big believer in omega-3 supplements, unless someone is eating sardines daily, which most people don't do. And I'm also a believer in things like turmeric and some of the other supplements, especially if they allow us to take fewer anti-inflammatory drugs.
Dr. Buckheit, I wonder if you could tell us a little something about stem cells. What are they and how should they be used? Are they useful at all?
It's a great question. Stem cells have captured the imagination of many Americans and people across the globe. That story started with a scientist, name was Dr. Arnold Kaplan, and he found these cells that were growing in our bone marrow that he could grow and turn into cartilage. And this was in the 1990s. Everyone thought he had a cure for osteoarthritis at that moment. The challenge is that when you take those cells and inject them into a joint, they live for a while, but then they die off. And it's really very clear now that what we call stem cells have a benefit for our immune response. So, for instance, we talked about that macrophage that flips a switch. They will flip that macrophage switch, but stem cells are actually working through our own immune systems. So the cells that someone gets injected into a knee, a hip, or a shoulder, they're not living long term. They're not growing new cartilage. They're turning on our own repair systems. And that's the myth that's been out there for a very long time, is someone thinks that they're going to have a stem cell injection, they're going to grow new tissues. They may have much healthier tissues, but those cells that are injecting aren't living long term.
So, but what I'm hearing you say is there still could be benefit.
Absolutely. Absolutely. The cells can be very beneficial in a lot of ways. There's many ways to harvest them. You can harvest them from bone marrow. You can harvest them from adipose tissue. Now, stem cells have also become controversial because they can come from ourselves, like PRP or the autologous conditioned serum, or they can come from a donor. And those donor products, you might imagine, need to go through a higher level of regulatory scrutiny to make sure that there's no infection that occurs in that process.
I would want them to be regulated.
Absolutely. And so there really are yet to be any approved stem cell therapies from donors in the United States. If you hear of people going overseas to overseas clinics, various countries around the United States, they can do those incubated products over there, but you really can't do it in the United States right now.
I'd like to ask you about cost. I guess, but I could be completely mistaken, that insurance companies are going to do their best to deny things like prolotherapy or PRP injections, or maybe even the autologous, what do you call it?
Conditioned serum.
Conditioned serum. If they could say, no, we don't really pay for that. How much would it cost if somebody had to pay out of pocket?
Well, it's a whole spectrum, right? There are certain things. Prolotherapy is very inexpensive, and stem cells and autologous conditioned serum are much more expensive. And it is true, insurance doesn't cover any of these right now. I think eventually they will. My way I look at it is insurance covers therapies that suppress the immune system. They don't cover therapies that augment the immune response.
That sounds crazy.
But it's true if you think about it, right? If you want a steroid injection, it'll be covered. If you want, an anti-inflammatory medication, it'll be covered. But if you want prolotherapy or PRP or any of the other therapies we're talking about, it's not. We also need to redo some of the studies. I mentioned before some of the PRP studies that were negative because what they were using really wasn't strong enough. And the insurance company can very easily point to that study and say, look, here's a large randomized controlled trial that says it doesn't work. It's experimental. We will not cover it. So I think it's incumbent on the field to redo these studies and redo them in a strong way, in a multi-center way, with good products, and then have the evidence. And I think that will happen, but I think it's going to be a few years.
Dr. Buckhead, we've talked today about arthritis and what you do about it. We haven't really talked as much about what causes it. We have talked about chronic inflammation. And so I want to ask you about one potential cause, which would be infection. For example, a Staph aureus infection, a Borrelia burgdorferi infection. Do you have anything to say about that?
It's not an area that I know deeply. I know it is one of the things looked at, and it makes sense. Any driver of chronic inflammatory change is going to chew up cartilage. And if you think about it, so if you have a chronic inflammatory state, regardless of what's driving that inflammatory state, your body's going to produce enzymes that digest cartilage tissue. And that's what osteoarthritis is. It's the enzymes. The inflammation releases the enzyme digests the tissue. And so we need to find a way to prevent that from happening. But any chronic inflammatory state would do that. A chronic infection would do that. A chronic inflammatory state would do that. An injury that hasn't quite recovered would do that. So I'm not an expert in the infectious cause, but if a chronic infection causes chronic inflammation, absolutely it could drive osteoarthritis.
Dr. Buckhead, I'd like to ask about pain, because pain gets your attention very fast.
Yes, it does.
And people want relief, and they can't sleep. Their back hurts, or their shoulder's giving them trouble, and they can't lie on their shoulder. It used to be that doctors prescribed opioids in massive quantities, Percocet, hydrocodone, oxycodone, and of course now because of the opioid epidemic and all of the people who have died, there's a tremendous reluctance for both physicians as well as patients to rely on opioids, especially long term. What's replaced opioids, however, is gabapentin. It's a anti-seizure drug, at least that's how it was originally developed, and another medication that has both an sort of antidepressant-like activity as well as some subtle opioid-like effect called tramadol. These are the big pain relievers these days. Your thoughts about gabapentin and/or tramadol and what we should be doing instead?
That's a great question. So I've been using and seeing people on gabapentin since the late 90s when it came out, right? And it came out, as you pointed out, as a seizure drug. It does, and it can reduce nerve pain. We talked about nerve pain being from if you have a nerve that's entrapped, it starts firing on its own spontaneously, and gabapentin can quiet that down. The challenge with gabapentin and the concern about gabapentin, though, is that it will affect the brain. It was designed to affect our brains as a seizure drug. And so I think it's a bit of magical thinking to think that we're not going to have cognitive side effects to gabapentin over time. And that's my concern. Some people can do very well with it. Some people need it because they cannot function because of a neuropathy or another issue. But a lot of people are on it, and I do have concerns about the cognitive side effects.
And the person who says gabapentin gives me such brain fog I can't function, they shouldn't be taking it.
If they can avoid taking it, sounds like a good idea to avoid taking it.
We like to say that pain is personal. Everybody's different. And, my mom, for example, if she had a bellyache, it would be like a 10 out of 10. I mean, she was just incapacitated. Terry's mother, on the other hand, cut to the bone, and she'd say, "Oh, maybe my pain's at 2." She was a tough old bird. And so the idea that we can generalize about your pain is very challenging. Some people get great benefit from gabapentin. Other people say it didn't work hardly at all. How do we find the right strategy for pain relief?
Oh, it's hard. It really is hard. And this has been decades and decades of pain research trying to identify therapies based on symptoms. I tend to look also at function. The reason is that if I have someone who's having 6/10 knee pain and can walk a quarter of a mile, if we do a therapy on them and they can walk now 3 miles, but their pain is still 6/10. That's still an improvement, right? Their function is better. And my hope is that as the function improves, the pain will eventually follow. But it is hard because, right, pain is in us, and it is subjective, and no one can experience it outside of the individual. And that makes it hard to gauge, right? But the other part of this is that we've tried to objectify osteoarthritis, for instance, by looking at an x-ray and saying this is grade 1, 2, 3, 4, depending on how big the space is between bones. And it turns out that there's very little relationship between someone's function, someone's pain, and how much space is between the bones. So our attempts at defining treatments based on x-ray is equally as poor. So I think pain is an important part of this, and it's a very important part of helping someone to function better. And you're right, there's no other way of doing it other than just asking them and talking to the patient.
Well, we only have about 2 minutes left, and so this gives us the opportunity to summarize all of the things that we should be doing and some that we should not be doing to allow us to keep moving, which is critical to your game plan, and to reduce our likelihood of ending up in pain for a long period of time.
Well, I think first off is figure out where you're starting. Everybody starts at a different place, but I like to say, measure where you are, and maybe you can walk a quarter mile, maybe you can only walk a few steps, maybe you can go and do aquatherapy. Find out where your level is of exercise, and then work on building that, but build it slowly. If you have someone who can't walk more than a quarter mile and they go walk 2 miles, they're going to be in bed for 3 days, and then they've lost ground, right? So,
and walking is good. You don't have to be a marathoner to benefit from just plain walking.
Exactly. And the studies for osteoarthritis are very convincing. Walking is good for joints.
What about diet?
Live like the folks that are in the Mediterranean basin. So I always think of fish, fruits, vegetables, nuts, olive oils as the foundation for food. And that diet that's good for our hearts is also very good for joints and nerves, and it's been shown and studied to actually decrease arthritis pain as well.
And when we sprain an ankle or injure a shoulder or our back is hurting, what can we do to avoid taking all those NSAIDs or getting those steroid shots to ease the pain and get us back moving again?
Well, that's a great question, and I would argue that we should not soak ourselves in steroid injections and anti-inflammatories. And I had this personal experience of having had a couple of knee injuries, and the first one a bunch of years ago, I soaked in anti-inflammatories, and then the second one I didn't. And I can tell from personal experience, it hurts more, but my healing was faster. And I would encourage when people can do it and go without the steroids and the anti-inflammatories to minimize or avoid them if they can.
Dr. Tom Buckheit, thank you so much for coming and talking to the People's Pharmacy today.
Thank you, Joe and Terry. It's been a pleasure to be here. Thank you for having me.
You've been listening to Dr. Tom Buckheit, author of Healing Joints and Nerves, Immune Stimulation, and the New Science of Regenerative Therapies. Dr. Buckheit founded the Triangle Regen Medicine and Biologics Center. He collaborates with colleagues at the Center for Translational Pain Medicine at Duke University.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
Today's show is number 1468. You can find it online at peoplespharmacy.com. That's where you can share your comments about this episode. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider, whichever one that is. You'll find the podcast on our website on Monday morning. In this week's podcast, you can learn more about stem cells and PRP. We discuss the pros and cons of pain relievers, including opioids and gabapentin. Pain is so personal. How can we find the right strategy for pain relief for each individual?
And because we are so individual, the one size fits all does not work. We have to individualize it.
Exactly.
At peoplespharmacy.com, you could sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you also have regular access to information about our weekly podcast. We would be so grateful if you'd write a review of the People's Pharmacy and post it to the podcast platform you prefer. If you find our topics thought-provoking, please share them with friends and family. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please do join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.
This episode is brought to you by Progressive Insurance. Do you ever find yourself playing the budgeting game? Well, with the Name Your Price tool from Progressive, you can find options that fit your budget and potentially lower your bills. Try it at Progressive.com. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law. Not available in all states.